Good evening, everyone. It is my pleasure to introduce Dr. Conrad. Dr. Laura Conrad is an attending physician in the Division of Respiratory and Sleep Medicine at the Children's Hospital of Montefiore. She's also the Assistant Professor of Pediatrics at the Albert Einstein College of Medicine. Dr. Conrad specializes in the treatment of children with respiratory disorders and has a particular interest in pediatric asthma. Dr. Conrad's interest in asthma extends to her research. She has focused specifically on urban communities where there's a high asthma burden. Her research during her fellowship focused on a predictive model of asthma, looking at autonomic dysregulation and future wheeze. Dr. Conrad has published in numerous peer-reviewed journals and presented in international conferences. Please welcome Dr. Conrad, who's going to be presenting her work on asthma and providing you with clinical updates.
Thank you so much for that kind introduction. I'm going to just try to share my screen here. I just want to confirm everyone can hear me and that everyone is just seeing the slide. Is that?
Yes, we see you and hear you, and we see your slide as well.
Okay, great. Okay, thank you again for having me. It's my pleasure to talk tonight about an approach to management of pediatric severe asthma at an urban tertiary care center. So I don't have any disclosures. And our goals and objectives tonight will be to define severe asthma first and foremost, and then review some of the guideline-based approaches to severe asthma management and examine the role of biologics for severe asthma. So as many of you already know, asthma is a leading chronic disease in children, with affecting over 5 million children under the age of 18. We know that children face higher disease burdens, accounting for more than 40% of all hospitalizations and over 10 million missed school days a year.
Oh, sorry, Dr. Conrad. Would you mind hitting the present button?
Oh, is it? Oh, I'm sorry.
It might be stuck on a different screen.
Oh,
yeah, there we go. I think at the top. Yep, right there. Sorry about that.
Okay. Is that, we can see now, like this?
Oh, no, now I think you might be sharing an alternate screen.
Okay, let me see.
So that might be on the Zoom side where you'll have to switch what screen you're sharing.
I see. Let me just apologize for that.
It's all right.
What does that look like?
We see it now. If you could just hit the presentation button.
Because when I'm hitting presenter view, I see it on my end. Let me see.
Maybe try clicking the present on your side, and then when you hit share, just make sure you're sharing the one that shows it as a presentation. If that makes sense.
There's also the slideshow option. Maybe if you go from there, slideshow, and then I don't know if that will help it.
Yeah, I'm hitting this usually works. I can apologize. So right now you're seeing, because I'm about to hit the.
Yeah, go ahead and try clicking that. Let's see. Okay, yeah. So when you go to share screen on the Zoom, just go ahead and click, you know, your screen in general. and that should, don't click the PowerPoint presentation. Does that make sense?
Oh, I see. Okay. Yep.
Okay.
Okay. Let me try that one more time.
Yeah, no problem.
How does that look?
Perfect. Thank you.
Okay, great. Okay. Okay, so sorry about that. Okay, so we went through our goals and objectives, and I was talking about asthma epidemiology. So I think I left off that Black children are nearly 3 times more likely to have asthma compared to white children. And we also know that males are more affected than females. And we also know that here in the Bronx, we have some of the most severe asthma in the country, affecting more children in this neighborhood of the Bronx, of New York, compared to Manhattan, Queens, or Brooklyn or Staten Island. And so they're disproportionately affected with some of the most severe asthma. So how is severe asthma defined? So according to the American Thoracic Society and European Respiratory Society, severe asthma is defined as having severe exacerbations, as well as impairment and or low lung function, and requiring high dose inhaled corticosteroids with a second controller medication and or systemic corticosteroids to maintain control. And it's asthma that remains uncontrolled despite these therapies. So I want to take a moment to distinguish severe asthma versus difficult to control asthma. So when we're speaking about difficult to control asthma, it's asthma that's uncontrolled due to contributing factors, which I'll touch on more in a moment. But this is largely accounting for more than 75% of patients with severe asthma. There is a subset of patients who have severe therapy-resistant asthma. And these are patients where those contributing factors are addressed, but high-dose therapy is still required to remain controlled, or they require novel and advanced therapies. And so some of the contributing factors that I mentioned that can impact severe asthma are things such as medication adherence and delivery. So what medicines are they taking? Are they taking it regularly? How are they using their inhaler and their spacer? The environment in which they live in, comorbid conditions, as well as mental health. So severe asthma is estimated to account for about 5 to 10% of asthmatics, but this can be difficult to pinpoint the exact number due to how we define severe asthma in the literature. Severe asthma is not a single disease. We know it's a heterogeneous severe phenotype. And with that, we need to treat these severe asthmatics with phenotype-directed therapies. We also know that patients who have severe asthma have higher healthcare utilization rates and costs associated. And severe asthma exacerbations disproportionately impact Black and Hispanic children in the United States with substantial morbidity. So I just want to take a moment to highlight, this is from the APIC study, where they looked at defining children in inner cities in the United States, more than 700 children who they clustered into groups and defined their asthma phenotype based off of their symptoms, their allergies, and their rhinitis symptoms. And I just want to highlight 2 of the groups that carried a pretty high severe asthma burden, and this was their cluster B and cluster E that you can see here. And one of the groups had high A-to-P and exacerbation, and were very exacerbation prone, while another group with significant burden had low to no A-to-P and also very high symptoms. And this just goes to show what a heterogeneous disease asthma is and how we define asthma. We really need to be defining asthma on a personal level, and that will direct our therapies in the future. And so you can see here just all of the different subsets of asthma that there are. Patients who are atopic versus non-atopic, if they have injury to their lung when they are young, if they have obesity, all of these things play into what their specific asthma definition is. And so throughout this talk, I'm just going to kind of interject with a case because I think it can be helpful to wrap your head around some of these things. And so I'll take this case of a 7-year-old girl with poorly controlled moderate to severe persistent asthma who was diagnosed with asthma around 2 years of age. She's had 4 lifetime admissions, 3 to the PICU requiring BiPAP. She's never been intubated. She does have a strong family history of asthma in both parents. And she's currently on a she was on a medium dose ICS and montelukast for the last few years with persistent symptoms until the pandemic hit, and her symptoms got better. But since then, now she's had almost monthly ER visits and more than 4 courses of oral steroids in the last year. During her last admission, she was stepped up to an ICS LAVA, and she was found to be rhino-positive during that admission. So she was subsequently referred to our asthma center for further management. So this is a diagram taken from the GINA, the Global Initiative for Asthma guidelines, and I just think it's a good place to always start. Do we have the right diagnosis of asthma? So we always want to make sure that we get a nice detailed history and exam to confirm that they do have a diagnosis of asthma. And then we want to decide what workup we're going to do for the patient. And are they already on a controller? Will this impact what their spirometry results look like? What is that controller? So we want to get all of those detailed history and then perform the testing that's appropriate. So we usually perform a spirometry. We may do further lung function testing, such as lung volumes and a chest X-ray. So as I mentioned, confirming the diagnosis of asthma is important because as many as 30% of referrals for severe asthma are misdiagnosed as these asthma masqueraders or mimickers, as they're called. And you can see to the right a list including many of these mimickers, and some of them can also coexist with asthma. So vocal cord dysfunction is a classic example of something that can exist in addition to a patient also having asthma and make their exacerbation seem that much worse. They can have panic attacks. There could be something anatomical. They may have malaise if they were premature, intubated in the NICU. This is a big concern. They may have recurrent infections, and we want to be working them up for suppurative lung disease. Thinking about interstitial lung disease, immune dysfunction. So going down the list and making sure we're not missing anything in our workup. So again, we perform the testing. So in our case, we did have an X-ray from a recent admission that showed some hyperinflation and infiltrates. And then we were able to perform spirometry on this patient. And you can see that the pre is on the left and the post is on the right. And then we can see highlighted the percent change in the FEV1, which was 17%, more than that 12% that we're looking for. And it was significant. And actually this patient's FEF 2575, which is that middle part of the flow volume curve, dramatically increased as well to 70%. So again, going along with our case, this patient was previously seen by pulmonary and had an extensive prior workup done by the age of 4. They had a sweat test that was negative, a sleep study that showed primary snoring. They underwent a triple scope with a BAL that was unremarkable. They had a nasal ciliary brush biopsy that was negative, a chest CT with mild bilateral bronchial wall thickening, but no bronchiectasis. And so a lot of those mimickers have been taken off the table. They had an allergic workup that showed skin prick testing that was positive to cat, dog, roaches, and mice, and an absolute eosinophil count of 600. and a total IgE elevated at 243. So this is an allergic atopic child. So in addition to those asthma masqueraders, there are comorbidities that can exist with asthma, as I mentioned, and sometimes those mimickers and comorbidities can overlap, like with vocal cord dysfunction, but we consider things like rhinosinusitis, symptomatic reflux. Obesity is a large comorbid condition that we see in our patient population, in addition to obstructive sleep apnea. Eosinophilic esophagitis can sometimes present in these patients. ABPA, which is allergic bronchopulmonary aspergillosis, or other psychiatric conditions. Anxiety can certainly cause patients' asthma to be worse. So back to our 7-year-old, she had a history of reflux in the past, but that's now gotten better, and her snoring has improved since that last sleep study was done a few years back. And she does have allergic rhinoconjunctivitis that she treats with Zyrtec and Flonase daily, which seems to control her symptoms. And she does have eczema that she uses topical steroids for, which somewhat controls her flares. So I just want to go through the clinical management of asthma. We all are probably familiar with the EPR3 NHLBI guidelines that have been in existence for some time now. And there were 4 essential components to these guidelines: assessment and monitoring, patient education, control of factors contributing to asthma severity, and pharmacologic treatment. And these 4 components remain as important parts of managing asthma. So obviously the mainstay of treating asthmatics is with inhaled corticosteroids, and I'll speak to some of the changes in medications with the new EPR4 update. But we all know that if they have poorly controlled asthma, we're looking to put them on a controller medication. Also, an important point is to highlight that asthmatics should have some written form of a plan, such as an asthma action plan to refer to for their self-management. And we want to make sure that we're classifying their severity and their control. I'll touch on their control in a second, but when we look at their severity for usually the initial visit, we're looking at their symptoms, nighttime awakenings, their use of their rescue medication, and if available, their pulmonary function testing. And then at follow-up visits, we use the asthma control test, or the child asthma control test. There's different versions, the 4 to 11-year-old, and then 12 and above. And this is a really nice self-administered validated test, controlled screening that the patients can fill out. And if they have a score of 19 and above, they're controlled. And if not, then we know that we need to make some adjustments to their medications. I also tell patients all the time, not only do they need to take the medications that we've talked about, but I need them to come back and see me so that I can follow up with how they're doing. And I think sometimes patients get better on a medication and then they go off and then they feel fine for some period of time and then they end up sick again. And then it's not until that point that they come back. And I try to highlight for patients that coming back to the follow-up visits can help prevent those emergency room visits or unplanned visits to the pediatrician from happening if we can get ahead of some of their symptoms. And then it's important to discuss allergen and irritant exposure and control, and trying to mitigate as best as we can in a multi-factor way. So we do know that there are environmental and social influences of health on different levels. So to the right, this is a picture of the South Bronx. At a community level, air quality is not something that patients can control in their environment. Housing, access to healthcare, what their food access looks like, their education in their specific neighborhood, what is their school environment, what environmental allergens like pollen are they exposed to, things like violence. We know that ACEs are important to screen for. And then in their specific home environment, what are their pests, mold, pets, tobacco smoke, dust mites? Are there things that we can try to mitigate on that level? Here in New York, we have a program called Healthy Homes, which is for patients who have persistent asthma, a healthcare provider can make a referral to use as a resource to reduce those indoor allergens in the home of patients with asthma. And Montefiore has also instituted a new community health worker referral program, which has been very helpful to help have these patients be plugged into these resources and having somebody advocate for them and help mitigate some of these situations that can be exacerbating their asthma. So back to our 7-year-old case, she lives in an apartment. They previously had a cat, but they recently rehomed the cat. There are neighbors who smoke in the hallway, which is out of their control. They have issues with roaches and mice, and they have noticed mold and water damage that has not yet been repaired. But mom says that they are getting ready to move. So you may be familiar with this. This is this stepwise approach for the GINA guidelines. And I'd like to just highlight at the top, they have this model of assessing, so confirming the diagnosis of asthma, as we said, assessing their technique and of their inhaler, looking for those comorbidities and masqueraders, and addressing what the patient's goals are for care, and then adjusting those treatments based off of the things that we learned when we were assessing the patient, and then reviewing the symptoms, the exacerbations, side effects of medications, and how satisfied the patient is with their asthma management. As providers, we do face many challenges. There is poor adherence with asthma self-management. We know that 30 to 70% adherence to prescribed controller medications is the range, which is a large range, and that 80% adherence usually means good control. So below that, we may be running into some issues. And that less than 50% of patients successfully complete environmental control measures, and that more than 50% of children with asthma are exposed to secondhand smoke in the home. As providers, we're dependent on patients' behavior in addition to giving them the medication, we have to rely on them to buy into what the plan is and to give those medications. They have to be, parents and patients need to be actively engaged. And up to 20 to 40% of controller prescriptions are actually never filled. Now, that being said, you can see that there are many different asthma medications, and it's confusing. Patients may have gotten one pump from the emergency room, another from an inpatient admission, another from an urgent care, the primary care, or a specialist, and they're confused at what to give. What color is it? They kind of look similar. How does this one work versus that one? Maybe the insurance didn't cover one type, so they got an alternative that maybe isn't the right medicine. I always ask parents and patients to bring in all of their medications so we can go through them together. If that's not possible and it's still very confusing, I will make a phone call to the pharmacy that they say that they go to and try to figure out what medicines are there, what has been picked up, and what adjustments we can make. And then we will show them with demos what pumps we're going to put them on and how to use them. So back to our case for a second. Mom states that the patient has pretty good adherence. She might miss 1 or 2 doses of the controller medicine during the week when they're running out the door in the morning to go to school. But she mostly uses the spacer with her MDIs regularly with her ICS, her controller, but not always with the albuterol when they're out of the house. So as I mentioned before, I'm going to just circle back to the EPR4 asthma guideline updates. And just as a refresher for the timeline of these guidelines, so we hadn't had any updates since 2007 when the EPR3 had a full guideline revision. And so they met in around 2014, 2015 as a panel, an advisory panel, to come up with recommended updates for the guidelines. And they selected 6 areas to review in the literature. And then in 2020, we had the specific updates. And so there were 6 areas, 6 topics with these key questions addressed. And there were two new topics included, which were fractional exhaled nitric oxide, or FeNO, and long-acting muscarinic antagonists, or LAMAs. And then in terms of the controllers, I'm not going to go through all of the updates. That's a whole other talk. But in terms of controller medications that are relevant to severe asthmatics, the large update, as I'm sure many are familiar with now, came to these step 3, 4, and 5 patients, of where SMART, or same maintenance and reliever therapy, was the new recommendation. So they're taking daily combination ICS formoterol as well as PRN. And this was a large change as opposed to on the alternative pathway, where the EPR3 update or old guidelines were to use the ICS formoterol and then albuterol as needed. And again, this is for all patients 4 to 12 years old in these step 3 and 4 patients. So again, this became the preferred recommendation to use daily and as needed combination, low or medium dose ICS formoterol, depending on which step that you're at, for all children 4 and above. And just to highlight that there is a cap on the number of puffs per day, and that's based off of the formoterol dose dependent on the child's age. So for the 4 to 11-year-olds, it's a maximum of 8 puffs per day. And for those 12 and above, it's a maximum of 12 puffs a day. So if they're on 2 puffs twice a day, you subtract 4 from that number, and that's how many puffs they can use as their rescue. I just want to pause here to talk about some limitations and considerations. So in prescribing 2 pumps for SMART, we are limited by payers, the FDA, pharmaceutical companies, and pharmacies. It's not approved for the use of rescue technically. So we run into a lot of insurance issues with that. This inhibits our ability to prescribe more than 1 inhaler a month. I also want to highlight that we have to be cautious in any substitutions, because SMART is meant for the LABA, long-acting beta agonist, of formoterol, because it has a rapid onset of action, and it can be used more than 2 times a day, where salmeterol, another LABA, has a slower onset of action and has not been recommended for the use in SMART therapy. Just to highlight that almost exclusively all of the SMART studies were done with budesonide formoterol as the combination inhaler, although theoretically any ICS with formoterol could be effective. And there is still limited evidence for SMART and therapy and its role in exercise-induced symptoms. And then lastly, we need to have the families buy-in. In the Bronx, we have a lot of patients who have a strong family history of asthma and are used to managing asthma in a certain way. And so we have to re-educate, if we're choosing to give the SMART therapy, about how to use the pumps appropriately. So here, one of the areas that was updated was the LAMA, the long-acting muscarinic antagonist. And so I just want to highlight where that falls in the steps. So it's part of the alternative pathway for step 3 and 4 patients. So you could add it on to their ICS to their ICS in the alternative pathway. And it's the preferred pathway for our step 5 severe asthma patients. So the new recommendation is for triple therapy, which is your ICS LABA combination plus a LAMA. And then the other point that was highlighted in the update was this fractional exhaled nitric oxide, which is, or FeNO, which they deemed may be useful in individuals who are 5 and above, who have an unclear diagnosis of asthma or have uncontrolled allergic persistent asthma needing frequent assessment. And this is something that we regularly use in our evaluation of our severe asthma patients. And you'll see its role in deciding more advanced therapies later on in the talk. So just to summarize the key updates from the EPR4 related to our more severe asthma patients. It's the role of SMART in those step 3 and 4 patients, the role of LAMA as an add-on for individuals 12 and above, as triple therapy for their step 5 patients. And actually, when the guidelines came out, it was only approved for 12 and above, but it's now subsequently been approved for 6 and above. And we do regularly use it in patients who are able to perform the technique of the inhaler for children 6 and above. And again, FeNO may be useful for those individuals 5 and above with either an unclear diagnosis of asthma or uncontrolled allergic persistent asthma needing frequent assessment. So I just want to highlight that a key area that was missing from the update was biologic therapies. And I think that this timeline could highlight why. So as I mentioned, the questions that the panel put together were back in 2014, 2015. And back then we really only had 1, maybe 2 biologics on the market for children who were 12 and above. And since then, we've had this explosion of biologic therapies that are available for our asthma patients, now all the way down to 6 years and above. So the original omalizumab has been around since 2003 for children 12 and above, and in 2016 got approved for 6 and above. Mepolizumab has been around for children 12 and above since 2015, and then was approved for children 6 and above in 2019. And then benralizumab came to the market in 2017, and this is the newest one to be approved for children 6 and above this year. And then dupilumab came out in 2018 for 12 and above and was approved for 6 and above in 2021. And the newest biologic on the block is the tezepelumab, which is now available for 12 and above since 2021. And I'm going to walk through all of these in a little bit more detail a little later. So back to our 7-year-old, she's been continued on high-dose ICS-LABA and montelukast. We decided to add on a LAMA since her asthma was poorly controlled. We reviewed asthma education and the importance of the use of a spacer. She returned 2 months later, and she still has persistent symptoms despite improved adherence and taking the LAMA. They did move to a new building, but in discussion with the family, we decided to start a biologic. So when do we use a biologic in these severe asthma patients? So again, we've confirmed the diagnosis, we've confirmed their severity, we've confirmed and that it's a refractory severe asthma and not just difficult to control. We've reviewed medication adherence and technique. We've tried to mitigate anything in the environment that we could. We addressed their comorbid conditions. They've started triple therapy with that ICS-LABA, LAMA. And so now what do? We look to the biologic. So this is from the EPR4 steps. You can see it's mentioned down in the bottom right to consider adding on a biologic without a lot of guidance. And then from Gina in the step 5 patients, you can see here that they also mention considering biologic. The GINA guidelines back in 2022 added this difficult to treat and severe asthma management guideline, and they do update it every year, trying to include some of the newer biologics on the market for children. So again, going back to confirming the diagnosis of severe asthma and then assessing their phenotype and considering adding on a biologic. Excuse me. The last update was in 2022 for the severe asthma guidelines. So again, looking at the biomarkers, which I'll touch on in a minute, and assessing if they have hypereosinophilia. Do we need to work them up for other conditions that could be causing their hypereosinophilia besides just asthma? We want to really assess their phenotype, which with biomarkers, which I'm going to talk about a little bit more. And then we want to consider adding on that triple therapy and maintenance oral steroids is really the last resort these days because of the therapies that we have available. So it's a little confusing. Which biologic am I going to choose? So we want to first look at their endotype and phenotype to the best of our abilities. We talk about T2 high and T2 low asthma, and if those what biomarkers are present. We want to engage in shared decision making. This is very important. What are the logistics for these biologics? How often are they given? Are they able to be given in the home? Are they comfortable doing that? As of today, we have 5 biologics approved for pediatric asthma, as I showed you. And again, I'll talk about them in a little bit more. But there are no head-to-head randomized controlled trials comparing these biologics for severe asthma. And so deciding which one to use in which patient is really a matter of having this conversation with the patients and looking at their phenotype. So this is a table that summarizes the biologics that are approved for children and adolescents for asthma. And so the first one is the one that's been around the longest, omalizumab. It's an anti-IgE that binds free IgE, which inhibits the binding to the receptor on the mast cells. And it's indicated for severe asthma. It also can be used in nasal polyps and chronic idiopathic urticaria. And this year has also been approved as an adjunct for food allergy. It's available for children 6 and above. The dosing varies for this medication. It's based off of the patient's total IgE, their weight, and then that determines how many number of shots and how frequently they're getting it. These are given sub-Q, and they are now available to be given at home. There is a real risk for anaphylaxis, and so all patients who have this medication need to have an EpiPen available. The next one is mepolizumab, which is one of our anti-IL-5 biologics that binds free and circulating IL-5. And it's indicated for severe asthma. It also can be used to treat chronic rhinosinusitis with nasal polyposis and eosinophilic granulomatous and hypereosinophilic syndrome. It's available for children 6 and above, and the dosing is based off of age, and it's given every 4 weeks. There's no loading dose, so it is every 4 weeks, and it can be given at home. It has for pre-filled syringes, and we look at their eosinophil count, preferably above 150, to be eligible for this medication. We don't look at their IgE for this medication. Next, we have dupilumab, which is an anti-IL-4 receptor antibody. It binds to the IL-4 receptor and blocks the downstream effects of both IL-4 and IL-13. It's indicated for use with severe asthma that has eosinophilia. It can also be used for patients who have moderate to severe atopic dermatitis. So it's a great choice for kids who have comorbid eczema, which we do see a lot of. And again, for that chronic rhinosinusitis with nasal polyposis or eosinophilic esophagitis. It's available for children 6 and above, and the dosing is based off of the indication and the age and their weight, and it's generally given every 2 weeks. So that's the buy-in that we have to get from the families, that it's given more often. Again, it's given sub-Q, and it's available in a pre-filled syringe. It can be given at home. Benralizumab is another one of our anti-IL-5. It's an anti-IL-5 receptor antibody, and it rapidly depletes eosinophils, and it's indicated for severe asthma. Again, newly approved for 6 and above. So this table from 2023 is lagging behind the times. Things are rapidly changing. But the dosing is every 4 weeks. It's sub-Q. It's every 4 weeks for the loading dose, and then it becomes every 8 weeks. I have some teenagers who like it because the frequency of the doses are less. And again, we're looking at the eosinophil count. And then the last is the tezepelumab, which is an anti-TSLP or thymic stromal lymphopoietin, and it binds very high upstream in the cascade and interacts with the receptor. Its indication is for severe asthma, again, for 12 and above. It's given every 4 weeks. It's sub-Q. It can be given at home, and there are really no biomarkers that are needed for this medication. And so it can be a good choice for severe asthmatics who are non-atopic, because as you can see, the other choices all rely on elevated eosinophil count, or in the case of omalizumab, an elevated IgE. So when we talk about the workup for these patients, we want to obviously look at their spirometry. We are looking at their CBC with their absolute eosinophil count, preferably off of oral steroids, because that can suppress their eosinophil count. We want to look at their total IgE, want to see what they're sensitized to. We do use fractional exhaled nitric oxide, or FeNO, which helps measure the eosinophils in the airway, and helps our phenotype our patients. Induced sputum is less commonly used in patient care. It's more often used in research, but sometimes we do bronchoscopies on these patients, and then we can get a cell count from that. So again, these are our biomarkers that are available. So the sputum eosinophils, as I said, are less regularly used in an outpatient setting. FeNO, we do look at looking at that airway eosinophilia. And then blood is easy and cheap to get, and we look at the absolute eosinophil count and the total IgE. So back to our case again, our 7-year-old was sensitized on repeat testing to tree pollen, cockroach, mice, dust mite, dog, cat. Her total IgE was higher at close to 2,000, and her peripheral absolute blood eosinophil count was 700. So it was elevated. So this is a nice figure from a relatively recent article about how do we choose a biologic. There's a lot of text here, but basically we're looking at the phenotype with those blood eosinophil counts, the IgE, what they're sensitized to, their lung function, and FeNO. And then the first thing we can look at is, do they have eosinophilia or not? So if they do not, and we want to see if they're allergic, if they're allergic, then we have omalizumab. If they're not, we have less options in the younger age groups. And if their FeNO is higher, we might be considering dupilumab. Again, if they have comorbidities such as eczema, that's a good choice. So you can see we would just walk along here and look at their blood eosinophil and their FeNO, and then decide if they're allergic or non-allergic and which choices there are. And I just would like to highlight for the 12 and above, all across the board, tezepelumab is an option because we're not dependent on any of these biomarkers. So we do have options, and we narrow it down for the patient based off of their phenotype, and then discuss those nuances of delivery, how often, and what the patient is willing to do. I just want to highlight there are limitations with biologics. This is older now from 2019, but this is just highlighting the number of participants for these phase 3 clinical trials with these biologics. So in green is all participants, and blue is pediatric participants. So we limited number in these medications. And then again, looking at this number of studies with enrollment of subjects less than 18, that's in blue. So the longer they're on the market, the more information we're getting on safety and efficacy. But again, these are all relatively new, omalizumab being the one that's been on the market the longest. Everything else has been within the last 10 years or so. I just want to highlight some challenges and future directions. So as I mentioned, the evidence in children is limited compared to adults. We have a paucity of high-level evidence to support and guide clinical decision-making and biologic selection. We don't have a universally accepted criteria for what response is. and it's unclear when to potentially discontinue therapy. And we don't really know what disease remission looks like and what are the long-term outcomes. So patients ask, like, well, how long do I have to be on this for? And will this be for the rest of my life? So I tell patients we will generally keep them on a biologic for 6 months before we reevaluate and decide if they need to switch therapies if it's not working, or to consider stopping. Although usually the first thing I do when patients become controlled on biologics is to peel off some of the daily inhalers that they're on and lower the doses of the inhaled corticosteroid that they're seeing. And this can be helpful in how much burden their asthma is when they feel good, and how many pumps they have to take during the day. And so back to our case, we decided to start Dupixent. She gets it twice a week. She's been on it for a year now. She's doing it at home. Mom was a little hesitant at first, but she learned how to do it and was happy to do it at home. The girl says that she feels great. She started playing volleyball. Her PFTs have normalized, and her asthma control test is 25, which is well controlled. And so everyone is very happy that this life-changing medication has improved her lifestyle. They don't have the fear of her ending up in the PICU, and it's like she's a new kid. And so I just want to take a moment to highlight that for managing these severe asthma patients, it's really important to have a multidisciplinary care team, making these big decisions with family, making sure we're not missing any comorbidities, masqueraders. And so it's been shown that dedicated severe asthma programs are efficacious in reducing asthma burden. And this multidisciplinary approach is shown to decrease healthcare utilization, improve asthma severity, and improve quality of life of patients and families. And so here at Montefiore at CHAM, I have the pleasure of serving as the director of our Pediatric Asthma Center. And our mission is to help our patients improve their quality of life by better understanding, managing, and controlling their asthma. And so we, just to give an overview, we're a comprehensive diagnostic assessment center for patients suffering from severe refractory asthma. And we have a multidisciplinary clinic involving pulmonologists, pediatric allergists, and a designated asthma educator. We now also have a social worker and a nutritionist. We develop individualized treatment plans to promote normal physical activity, prevent sleepless nights, and reduce missed school days due to asthma. And so we get referrals both internally and externally for patients who have been hospitalized for asthma within the past year or have multiple emergency room visits in the last year. Patients with persistent symptoms needing frequent courses of systemic steroids, or patients who are believed by their primary care providers to be poorly controlled despite what would seem like adequate treatment. And so with that, I'd be happy to take any questions, and I thank you for your time. I'll stop sharing so I can see if there's anything in the chat.
All right, thank you so much, Dr. Conrad, for that presentation. Does anyone have any questions before we say our goodbyes, our good nights? I do want to, oh, okay. Jacqueline Bitterman, use of combo med. Dr. Conrad, you mind looking at the?
I think it's use of, SABA and ICS did that. There's a new, I think you're referring to the new medication, or Supra, that came to the market, that it's a combination of an ICS and a short-acting beta agonist. It's currently not approved for children, although I do think that this will be something that will have to be revisited in the next update of the guidelines, and when to use that. I think just speculating, it could be something that could be good for children who have that intermittent use of ICS, which I didn't highlight specifically in this talk, but that's one of the EPR4 updates that happened in 2020. And so I think more to come on that for sure.
Can one just ask a question instead of typing, etc.? How effective are the various biologics with teenagers who are smoking?
That's a good question. In my experience, patients who have been placed on the biologics have done tremendously well, whether they're lying to me if they're not smoking or not. But it has been dramatically improving their quality of life. And I think that I've also found that in teenagers, once their asthma is improved, their whole morale improves and their desire to have a healthier lifestyle in general, with like obesity and activity and not engaging in some of those behaviors. I think that also changes. I get a lot of, really like depressed and anxious teenagers with their severe asthma. So I think it helps them overall, but that's a good question. I don't know about the details of that in the literature, but
A mixed blessing, because it's good that it's helping them, but of course you want to get them to stop smoking, and if they're smoking, then you give them something that takes care of the problem. It kind of takes away the urgency to get them to quit, unfortunately. But we'll have to deal with that.
yeah.
I think there was one more
Thank you.
question. Karen Warman.
Side effects on Dupixent. Yeah, that's a good question. It's pretty safe. The most common, other than all of them have a risk of like local reaction at the injection site. There's a theoretical risk for anaphylaxis for all of them except omalizumab, which has a true risk of anaphylaxis. So it's a mixed bag of if people prescribe EpiPens for those patients, but the most common, like rarer side effect that I see with Dupixent is conjunctivitis, but it's not an indication to stop the medication. We usually will send them to ophthalmology and continue them on the Dupixent. I have had one patient who requested to switch and we changed their biologic because of it. But the other handful that I've seen with that specific side effect went to ophthalmology and symptoms improved and they stayed on it. I hope that answered the question.
All right, wonderful.